All right, what's going on? Happy Friday. Hey guys, what's going on? Hope everybody's doing well. Hope Friday is awesome for you guys, and hope your week has been great. This is your time, so whatever you guys want, your Friday performance and fitness Q&A. Throw some questions up there. On YouTube, you have the little chat that you can ask questions on. Obviously, on Instagram, you have the comment section. So whatever you guys want, we can talk about. Whatever you have on your minds. Hopefully, if you guys tuned in last week, we answered some questions on some lower extremity stuff and some assessments. But happy to talk more about it. I can wave back at everybody that's waving to me on Instagram here. Let's see. All right. So what do you got? Anything exciting? Anything you've seen, heard, want to talk about? Feel free to let me know. Let's see. Who are you? That's a good question. My name's Dave. So I do all the or most of the teaching for Bush Institute. Um, I've been working with Brent for a while now. I've been doing our Friday Q&As for a year and a half or so. Any fitness performance, anything along those lines, feel free to ask. Obviously, I know we get questions all the time on I have this injury or that injury. I can't really answer those sorts of questions on Instagram, right? So or YouTube. So any of those questions I can't really help you with. But anything else, talk to me. Fire away. Give me something good. Give me something good to get going, and we'll see what we can. We'll see what we can get into. Waving back at everybody, and we'll get going. Let's see. I don't know how many of you guys use an assessment like the overhead squat. I use that a lot, especially to kind of evaluate what we're doing and where we're going, right? So I think more than anything that that overhead squat can uses just kind of a big picture view of what your client patient any dysfunctions that they may have, and then you can kind of figure out what sort of protocol, what sort of intervention, what sort of modalities are going to be best suited for that person, right? So that overhead squat can give you a pretty good idea on what muscles are overactive, what muscles might be short, what muscles might need to be strengthened, and also what joints potentially might need to be mobilized, right? So that gives you, like I said, just kind of this overview and kind of go from there. Global Horns on YouTube. What's the optimal set and rep volume for beginners and intermediates? Well, it's a great question. The answer for that question is it's going to depend on their goals. So let's say we have this beginner who wants to just kind of improve overall function. They want to feel better, move better, whatever. I would start them out in some sort of progressive type routine where you can go from, let's say, the stability endurance phase to the general strength or hypertrophy phase to, a couple other phases that might be sprinkled in there, or a combination of phases that could be sprinkled in there. But let's say we take that beginner. What I would probably recommend for that person, again, it's going to be very dependent upon what that person can do and their capacity. But you're looking at somewhere around 12 to 20 reps at let's say, a 3-2-1 tempo. So 3-second eccentric, 2-second isometric, 1-second concentric. And you're looking at like 30 seconds or so of rest time. Obviously, if they need more rest than that, you can give them more rest than that. But I would probably focus on more of like a total body routine for that beginner. I'm not just going to do chest day with that beginner, but that's kind of where I would start, right? And let's just call it somebody who wants to, a beginner who wants to just kind of like get moving, improve function. Okay, yeah, they may have some specific goals of, let's say, weight loss or muscle gain or whatever, but that's kind of where I would start. And then from there, for 4 weeks or so, let's call it a month, right? We'll progress to the next phase, which would be like that general strength, where now the loads can get a little bit heavier. we're going to do maybe a little bit more or a couple more sets, but the repetitions are going to be slightly decreased. Since the load's up, the repetitions are going to go down. So those are kind of inversely related. So that's kind of where I would go with that. Now, as they progress into being more intermediates, we can play around with some of those tempos, or we can play around with some of those rep ranges, and kind of combine some phases together. So after they've gone through that stability endurance phase, then they've progressed to that general strength hypertrophy phase. And let's say we've done that a few times. What we could do is almost do like supersets where we could go into a general strength exercise, 6 to 12 reps, right to a stability endurance exercise, working the same muscle group. And it just adds a little bit more of a challenge. So that essentially the volume goes up a little bit. Um, and kind of go from there. So that's kind of my first recommendation, especially for beginners. That 12 to 20 rep range, something that's still challenging, but not going to put them, cause them not to be able to get out of bed the next day, um, and focus on kind of a total body routine. So let's see. So hopefully that's helpful. If you have more, if you want more specifics, let me know. Just keep chatting away and I can expand on that. But that's a great question to get us started. And I hope everybody with your clients and even patients, if you're in the orthopedic side of things or the PT manual therapy side of things, hopefully you're all doing some sort of progressive based training or coaching with that person, whether that client or that patient, right? One problem that I see all the time is people go into the gym going, I'm going to do 4 sets of 10 reps or maybe 12 reps, whatever. And that's all they do all the time, right? Your body adapts. You never give a different stimulus and you start to plateau. So you have to make sure we transition through those phases, and make sure you have a solid program or at least a roadmap to know where you're going to go. Right. So hopefully that's helpful. Let's see, post client Patrick on YouTube, and then I'll get to my Instagram questions here. Um, PCL surgery, uh, kneeling positions tough. So instead of quadrupeds, you can certainly, obviously, if that person can't get into those positions or if they can't do that position, that exercise rather, then sure, you could add or incorporate some of those standing TVA core work. So what I would suggest, you could potentially do some pail off presses and holds. I don't know if you're familiar with them, but also chops. Don't forget those chopping patterns. More specifically, though, are the anti-rotation chopping patterns. So you're chopping with kind of your arms, but your torso is still staying stable. So you're still getting that TVA contraction there. You're still getting that work of that core musculature, and you're resisting rotation, resisting movement there. So I would definitely incorporate them if they can't get into do the quadrupeds. Obviously coming off that knee surgery, probably won't feel great. So hopefully that's helpful. Sprinkle in some chopping. There's all kinds of different chopping patterns and progressions that you can kind of play around with that kind of make that a little bit more difficult for that person. So you can progress it in various ways. And like I said, the pail off press, not that's fine. Go for it if that's what they can do, and if that's something that you feel like is safe to integrate into their program, then go for it. What exercises do you recommend for someone who's having a disc herniation in their neck? Make sure they are go see a physical therapist. So I'm not going to necessarily say, "Hey, you have a disc herniation. This is going to be the best exercise." They're going to need to make sure they're being treated appropriately by uh, their doctor, their physical therapist, their whatever, wherever they go. Um, they need to get specific treatment for that. There's lots of things that can happen. I'm not going to just throw out exercises and have somebody try that stuff. You really need to get a little bit more specific with that, and be careful with some of those things, not just because it's in the neck, but just in general. But what I would also recommend, if they are cleared to exercise and they're done their PT and they're done all that stuff, um, do your assessment and identify the dysfunctions that you see and treat the dysfunctions. But don't worry so much about the oh, you have a disc herniation. It's information that you need to know, certainly, but treat the dysfunctions, not the diagnosis, right? So more than likely they're going to have some upper body dysfunction. So you'll need some soft tissue work on those specific muscles in the upper body that are commonly overactive, and they're probably going to need some activation on some of those muscles that um, that are commonly underactive, like serratus and levator and longus coli, longus capitis, things like that. So, um, but just kind of keep that in mind, right? Hopefully that's somewhat helpful. 33 flat feet. Can you work out? Absolutely. When you're running, you have pain on your foot. Sure. Um, again, more than likely with that, you're going to have some lower leg dysfunction. So I'm assuming, right? So that flat footedness is going to be eversion if that's what you've assessed. So make sure you're doing your release of gastroc, release fibularis, activate your tibialis anterior, tibialis posterior. They're going to help counter that flat footedness and hopefully maintain a little bit of that arch. You may need to do some extra things, some ankle mobilization, some stretches, activations at the end, and then see how you feel and go for that run or go for that whatever you want to do and see if that helps. I would definitely suggest doing that assessment, doing the intervention, right? The release, the mobilize, the lengthen, the activate, the integration component, and then go do a short run if that's what you want to do and see how that works. One of the things that I recommend a lot for my runners is to when they go to the park or when they go for the run or whatever, bring a tennis ball, something like that with them. It's light, it's easy, it's simple. You can carry it around with you. It's not a big deal. It's not going to weigh you down. Um, you can do your release techniques there right at the park. You can sit on the ground or sit on a bench or whatever and do a gastroc release. You can do a fibularis release. Do your if you can do the ankle mob, awesome. But if not, do some stretches for the calf, and then do your tibialis anterior, tibialis posterior work. And you don't need equipment for that. You can do that with nothing, right? But do that 12 to 20 reps for each one, maybe 2 rounds through, and then go for the run. What I found is they feel and move a lot better. So yeah, so hopefully that's helpful, and go from there. Global Horns back on YouTube. You do online training. How do you go about assessments? Just because they're online doesn't. I'd still try and get an assessment every so often. We'll do FaceTime or YouTube or not YouTube, or FaceTime, or they can send videos through YouTube, or they can do whatever. Send you a video of themselves and text it to you. Um, but I still do or Zoom, right? I use Zoom for some of my clients. So that's kind of how I do the assessments, and then the workouts and things like that, they get sent out through email or the app or whatever you're using. But that's kind of where I would go from there. I definitely would suggest meeting with that client at least once a month or so to see the progress, right? And hopefully at some point you get into the time of like, we don't really need to see you anymore because we've been working on all these, or we don't need to do the assessments like we did at the beginning because we kind of know we've nailed down what those dysfunctions are. We nailed down what they need to work on the most. And, you just get a little bit better and better and better at that. And it ends up being a quick, easy, simple assessment each and every time. So. Hypoactive glutes are related to poor dorsiflexion. Potentially, what's interesting about glutes and TBA um, is that with really any dysfunction that you see, from lower extremity dysfunction, obviously lumbopelvic hip complex dysfunction, and even some upper body dysfunction potentially, but really lower extremity and lumbopelvic hip, glutes end up shutting down for everything. Um, it's weird. It's kind of a funny little, I don't know, kind of funny little piece there. Obviously, any sort of lumbopelvic hip, glutes are going to be lengthened. They're going to shut down. But even things like spraining an ankle has been shown to shut or decrease glute activity. You stub your toe, your glute shut down. Right? You have a bad day, your glute shut down. They're the prima donnas of the body. They go, I can't work in these conditions, right? And they just shut down. So um, obviously, if you have somebody with lower leg dysfunction or poor dorsiflexion, it would be great to work on those tibialis anterior muscles, so that the dorsiflexors. but also, it wouldn't be a bad idea to throw in some glute work, throw in some TVA work, and see what you get, right? So hopefully that's helpful there. Sorry. Let's see. TMJ, go see somebody. If you got TMJ, go see a PT, a chiro, orthopedic, somebody that has a little bit larger scope of practice and can do, some things in there and do some evaluation in there. So, sorry, I can't help you more than that, Donald. Professional show jumper, balance is poor, dorsiflexion limited. What would you recommend to target first? So, great question. Um, uh, Assess, right? Assess, and here's the hierarchy of treatment, right? So number one, when you do that assessment, and then you do the assessment with modification, right, with the heels elevated and hands on the hips, you can really gain a better idea of what's going on, what segment is the problem segment, right? So a lot of times we find, not always, but maybe in this case, maybe not, but a lot of times we find that people are lacking dorsiflexion, right? And that lack of dorsiflexion contributes to a lot of the common dysfunctions that you see elsewhere. So um, do the assessment, do the assessment with modification, identify the where most of those dysfunctions are coming from. Then the hierarchy goes most obstructive dysfunction. So um, they have ankle pain, they have some plantar fasciitis, like we were just talking about. I'm gonna not worry, not treat that pain, but I'm gonna go, okay, I'm gonna focus on lower extremity dysfunction. They have some back pain or something along those lines, or hip pain. I'm gonna focus on lumbopelvic hip complex dysfunction. If they have shoulder pain, neck pain, right, whatever, I'm not going to focus on the pain. I'm not going to go, oh, you got neck pain, let me work on your neck. I'm going to say, okay, cool, that information is valuable to me. I'm going to treat the upper body dysfunctions that I see. So that would be step one. Step two would be, let's say they don't have any obstructive dysfunctions. Then we'll go to the any asymmetries that we have. So asymmetry is a big predictor of injury. So from the most obstructive dysfunction, we'll go into asymmetries. If they have one ankle that's got great dorsiflexion and one ankle that doesn't, I'd focus on the ankle that doesn't have dorsiflexion that we need. If we have one arm that's like perfect and the other arm's like not even able to get up, bring that arm up, then I'm going to focus on that side that's restricted. So that would be the next step. Then we'd go to the most dysfunctional segment. So if you had, let's say, a little feet flattened, but um, anterior pelvic tilt and knees bow in, coming from lumbopelvic hip, right? My most dysfunctional segment would be the one that's contributing to both anterior pelvic tilt and knees bowing in. Right? From there, if everything's kind of even and you still don't know where to go, work from the ground up because dysfunction tracks more from the ground up compared to top down. So again, I hope that gives you a little bit of an idea of where to go, what to start with. Start with any obstructive stuff, then go to your asymmetries, then go to your most dysfunctional segment, then go to the ground up. Now, obviously, um, if she's sent to you by a physiotherapist that maybe she had some problem somewhere, I would start in that segment: upper body, lumbar-pelvic hip, lower extremity. So hopefully that's helpful. If you have more on that, let me know, and we'll go from there. So let's see, 16-year-old tightness in his hamstrings. Stay away from stretches, right? I would go back. So this is the big problem here is that you can't use feelings as your facts. I can't come to you and say, oh, I feel my hamstrings are tight, and then I go stretch it. That's probably not the answer. Your feelings of stiffness or tightness or whatever can be from a lengthened muscle, right, or a short muscle. Pain can be from an overactive muscle and underactive. So there's lots of the feeling side of things you can't use. Do the assessment. More than likely, what you're going to find is, especially in the youth or the younger populations, they're going to have dysfunctions. They're going to have some muscles that are more developed than others, and some muscles that might not be pulling their weight, so to speak. So do the assessment, identify what you see. That tightness in the hamstring could be from a an underactivity of the glutes, so the hamstrings are doing more work than they have to, and stretching it's not going to make it any better, right? So maybe a better approach would be, and I'm just throwing this out there, maybe a better approach would be to say, all right, we looked at the assessment. We've identified glutes are underactive. I'm going to leave the hamstrings alone, and I'm going to focus more on glute work, some TVA work, things like that, and then reevaluate and see what happens after I do some of those things. Right? Oftentimes we find since glutes shut down, hamstring activity ramps up, and when glutes shut down, and we're thinking about an anterior pelvic tilt specifically, well, when you go into an anterior pelvic tilt, your hamstrings lengthen. So it would feel tight. And think about you being pulled forward. You're going to be lengthened, but it feels tight and it feels stiff. So if you go and try and stretch, you'll get a temporary relief, but then it goes right back to being an increase in tension. So I would try and stay away from the hamstring stretches. I'm not a huge fan of that. I'm also not a huge fan of hamstring strengthening. I think we need more focus on glutes than hamstring work. Uh, Weak groin, what do I do? What do I need to do to strengthen that? Again, I think what it comes down to is you probably have some sort of dysfunction or some sort of compensation, probably knees bow in, maybe knees bow out, or an anterior pelvic tilt. And I think you're going to need to focus more so on not the specific area that you think is weak, because we have that dives us deeper into this physiology side of things of a length tension curve. A short muscle is weak, a lengthened muscle is weak. So where do you fall on that spectrum? The only way we can find out is through an assessment. So do the assessment. You probably find maybe knees fall in, um, or anterior pelvic tilt, and that's kind of what I would focus on, right? And go into that, release the overactive, lengthen the shortened muscles, activate the underactive muscles, and integrate that into kind of a movement pattern. Can rigid flat foot be improved with exercise? So, what can be improved with exercise, specifically the corrective exercise approach, is not necessarily if they have some sort of structural thing, scoliosis, we talk about a lot. If they do have kind of a structural flat foot, which they're out there, sure. Um, what can be improved is the how they move and how the recruitment of some of those muscles in and around that foot or whatever we're looking at, right? So I would suggest still focusing on, okay, assessment, you have flat foot, right? Check that box. Cool. Let's do our interventions for flat feet. Even though I may not be correcting or fixing that structural flat footedness or that structural scoliosis, I'm not going to fix that. I'm not going to get them out of that, but what I'm going to do is I'm going to get all the right muscles firing before we go into our training session. So that's kind of where that's the approach. And again, people get sucked into this diagnosis thing. They always, I have structural flat foot, I have scoliosis, I have, X, Y, and Z condition or issue, whatever. That's fine. It's good information to have, but don't treat the dysfunction, or sorry, don't treat the diagnosis, treat the dysfunction, right? Treat what you see, right? Incorporate interventions based on what you see in their assessment, in their reliable assessment, and go from there. Um, Anterior hip pinching, especially in hip flexion, again, you're gonna hate my answers. It's all gonna come back to the same thing, right? It's all coming back to the assessment, but more than likely, what you're probably gonna find is somebody with an anterior pelvic tilt, somebody with knees bow in, something along those lines, maybe even excessive forward lean. They're gonna have, potentially have some, hip mobility component there that we need to add, so I would check out some of the self-administered hip mobilizations. So they're with the bands and they can help with a little bit of that distraction there of whatever joint, but we'll talk about the hip joint now. But we can do a little bit of distraction with that hip joint. I know my YouTuber sorry. And that might give that person a little bit more range or space there in that hip. Same thing happens at the ankle. I don't know if you guys ever tried to stretch your calf and you got a pinching on the front side of your ankle. You may need a little bit of a mobilization there um, at the ankle to give yourself just a little bit more space so you get a better movement or better stretch. So Ryan Roth, that's kind of what I would check out. Check out those self-administered hip mobilizations. See if that's appropriate for the client or patient that you're working with, and go from there. Heat and all those things, all that stuff. Um, I'm going to stay away from. There's certainly some benefits there, but one of the big things, actually, Brent just talked about this on Wednesday. Some of those treatments that they use, there has to be, in order for them to be effective, there has to be some carryover, right? And you just have to be careful with some of that stuff. And obviously, if you are not a if you're not a physical therapist, chiropractor, um, orthopedic, you should not, as a personal trainer, you should not be applying anything to your clients, right? You can't put ice on stuff, heat on stuff. You can't really do any of that stuff. So I would be very careful with that. And again, I don't know what your scope of practice is, but some of the heat, some of the products they have, like Hyperice has some stuff that people can put on themselves, like at the knees, the shoulder, the back, and that heat with vibration. Sure, there's some benefits to that. That certainly could be helpful, but just be careful with some of that stuff. In bridge, left hip lower than the right hip, it means left one is weaker than the right one, potentially, or there is a shift, right? So both of those could be correct. Both of those could be some problems there. So um, I would go back, see if there's an asymmetrical weight shift in that squat, see if there's one side a little bit more, a little bit different than the other. Maybe there's some sacroiliac joint dysfunction in there, which you might need a deeper look at. Or maybe you just need to focus on unilateral based training for that bridge. So a single leg hip bridge on the floor might be a good start, and then kind of go from there and see if you can kind of get that back to where you want it to be. So um, both, but like you said, one could be weaker than the other, right? And you'd find that real quick with doing single leg or unilateral versions. Or there might be a shift, right? And the only way you can tell is assess. How can you find out if you have an ACL tear? Go see somebody, right? Go see a orthopedic. Go see go see somebody. If you have an injury, I'm not going to tell you how to do tests on your own. That's not an appropriate or professional component on my end. So go see somebody, especially if you're in pain or if you have any of the issues or concerns about things like that. So cool. Good questions, guys. Happy Friday. Hope everybody has a good one. I got to get out of here, so I'm sorry. I will see you guys next week, as always. So I'll see you next Friday. Anything else you guys have, I'm going to post this on Instagram. You guys can ask some questions there if I missed anybody. Other than that, guys, go be awesome. Go have a great weekend. Go do great things. I'll see you guys next week.